I'd like to acknowledge and pay respects to the traditional people of the lands that we are meeting on. I'd like to pay my respects to the elders past and present, and I extend that respect to any traditional and community elders that are present here today. I would like to thank Koert, who is well known to you all for taking us through hemovolemic shock in the neonate. Koert works at the John Hunter Children's Hospital and is part of the Hunter Medical Research. He's published over 70 articles, and his main focus of interest is in neonatal cardiac function, the ductus arteriosus, and utilizing new echocardiography techniques for the understanding of neonatal cardiac function. So thank you, Koert, and welcome everyone, and we shall begin.
Thank you, Cheryl. Let me share this again. Oops. You got the full screen for this one? You do? Okay. All right. Thanks everybody for attending our new session on this lecture series. And today I actually gave a slot to myself. I presented this a long time ago, and I think it deserves a bit more attention. And I have added, of course, all the newest information to it, but I'd like to take you to a journey which is about hypovolemic shock. But actually the three components and three different types of hemovolemic shock, which is hemorrhage, dehydration, and relative hypovolemia. And as I normally do, I start with the physiology and see if we can get to the clinical implications of that physiology and understanding. So the beginning is the beginning. What is hypovolemia? And this is actually quite interesting. If you go look into textbook, what is the definition of hypovolemia? It depends a bit on the textbooks of which sort of medical entity you're looking at, whether it's renal or intensive care. The intensive care people would generally call hypovolemia volume depletion from the extracellular spaces. But if you look at more general medicine or renal physicians, they would talk about dehydration, which is the loss of intracellular water. So there's different sort of concepts of where the water has disappeared. So if we look at that, what the body water distribution is like, and of course this is a very old slide where your body weight is compartmentalized into solids in the bottom and body water on the top. And then you have your intracellular water here on the left and your extracellular water, which is interstitial fluid and plasma volume. And these compartments are separated, one by a cell membrane between intracellular and extracellular, and two by a capillary wall. But water, of course, can travel through these compartments using different kind of channels and activities. And the most important one, which we know, is actually sodium. If we go to the intensive care part, which most of our neonatologists deal with, then we come to this intravascular volume part. And intravascular volume is distributed in your heart and lungs, your arterial system, your capillary exchange vessels, and the venous system. And here the distribution is depicted of an adult, but there are certainly changes in the newborn, but they're not that significantly different. The control of these systems is with your autonomic nervous system into stimulation and via the sympathetic and parasympathetics for the release, and the longer term control with your renin-angiotensin system. So explaining this intravascular volume regulation into the physiology a bit further, then there are these two components which play a very important role. The signaling and the triggers for volume regulation is related, for instance, here on the left side, if your intravascular volume is low or your blood pressure is low, and there is actually a third trigger, which is related to low sodium in your distal tubuli of your kidney, then you activate your renin, and that can be sort of further activated on different kind of systems, your sympathetic stimulation and your prostaglandin system, which then goes to that cascade of angiotensin 1 and 2, aldosterone and ADH, or vasopressin as it's known. And that will then lead to sort of the reverse situation with vasoconstriction, sodium and water retention, and an increase in cardiac output. On the other end of the balance, you have when there is too much intravascular volume, when you're overloaded or your blood pressure is too high, that actually works via natriuretic peptide system, your ANP. This can be stimulated or activated by the parasympathetic stimulation as well. And one of the things, or actually two things it does, it actually blocks or start to sort of deregulate the RAS system, but it can also directly lead to vasodilatation, sodium water excretion, and reducement of your preload. So that preload is a new term which sort of creeps in if you talk about volume. Hypovolemia is not just volume, but it's also pressure, as you could see from those regulatory mechanisms. It is activated by either volume changes or pressure changes. And when we talk about pressure, we generally talk about the arterial system. We call that the pressure or the afterload. And we talk about volume, we generally talk about the venous systems. But as you can imagine from the cardiovascular system, this is not completely true. There's also pressure changes into your venous system, and there's also volume changes into your arterial system. And particularly the one on the venous system and how they are connected to your heart needs some further explanation. And this is a very old physiology slide where this big blue sort of tube represents the venous system. And if you have measured the pressure into it when it's standing still, that's called the mean circulatory filling pressure. And the venous system is, of course, filled by the arterial system and connected to the heart again, which we call to the right atrium, and that pressure which it's created over there, we call the central venous pressure, the CVP, which is an important intensive care term. But actually, it's not just one vessel. There is sort of, if you depict it as a vessel with an opening tube, which can be moved up and down, predominantly by the parasympathetic and sympathetic nervous system. That means that whatever fluid is below that opening is not pressure generating, and it's called unstressed volume. And whatever volume is above that tube is actually pressure generating and is called stressed volume. So this I found is, for me, the most illustrative way of trying to explain how the venous system actually creates that central venous pressure into your right atrium and how that can be controlled. And these backgrounds and this physiology, these concepts which I've just described, are probably important to then, what is the clinical implications of that? How, what clinical questions do we normally have as intensivists which are related to hypovolemia? And I posted 3. There are more, but I think these are the 3 which often are mentioned on other ward rounds or management decisions. The first question, is this baby actually hypovolemic? And then we need to determine what is the cause of the hypovolemia, and if that hypovolemia is absolute hypovolemia or relative hypovolemia. And I'll explain that a little bit later. The second question then, okay, will this baby then benefit from more fluid? And that term in the literature is called fluid responsiveness, and we'll go into that at the end of this talk as well. And how should that fluid then be given? Either as a fluid bolus or maybe as a continuous infusion over the day, which is related to prescribing fluid, which is probably not that often mentioned in the literature or in clinical practice. All right, is this baby hypovolemic? What are the causes of hypovolemia? And this one is specifically for newborns. I think there are 3 main causes. 1, acute hemorrhage or absolute hypovolemia, acute blood loss, which generally the majority of the loss will be intravascular. Then there is dehydration, which is also a form of absolute hypovolemia, which is different in its concept. It is intracellular and can be related to, for instance, insensible water loss, polyuria, or any way where you lose way more fluid than you should. And the last one, which is probably the most commonest form of hypovolemia in newborns, is vasodilatation. So this is a relative hypovolemia. There might be enough volume into the system, but due to the dilatation, this will give a different balance between the stressed volume and the unstressed volume. And we see this in the inflammatory response or infections and with medications. And it predominantly takes place in the extracellular compartment, which includes the intravascular compartment. So we're going to go to these three in sort of physical and data, which is available in the literature. And we're going to start with the first one, hypovolemia due to hemorrhage. As you can see here in this picture, that's how I would sort of graphically display it in the normal situation where you have your nice balance between stress volume and unstressed volume. During a hemorrhage, when you lose part of this volume due to bleeding, there will be a recruitment of this unstressed volume, and the stress volume is trying to maintain itself, but that can be tricky if the hemorrhage is still ongoing. This is a great paper I would recommend everybody to read from Barr, a very recent paper, which looked just at a very large cohort in babies who had anemia at birth. And they classified them as mild, moderate, and severe using the gram per deciliter below the first percentile, either less than 1, 1 to 2, or more than 2, which they called severe. And in a term baby, that would equate to probably less than 10 grams per deciliter at birth. And they classified them according to probable cause of this anemia. As you can see, hemolysis is the black bar on the top, which increases in the more severe kinds. But the biggest one which it increases is actually hemorrhage. Then there's hyporegenerative, mixed, and also unable to determine was quite commonly mentioned, particularly in the mild anemia forms. So if we go into more detail, what they found in this large cohort of that hemorrhage, it's about 1/3, which they call the perinatal events, either a cord or abruption. About 1/3 was fetal maternal hemorrhage, and the rest was either newborn bleeding or other. So these perinatal events in this same group from Christensen and his group, here presented by Tweddle in also a recent paper, they did these large retrospective reviews of all the data they had. And these is a representation in a graph of 564 cases of placental abruption and where the hemoglobin was reported early after birth. And they found that about 5% had a severe anemia. You can see the dot distributed and the normal distribution between the first and the 95th percentile in this particular population. So the message from this paper was that placental abruption, although common, actually not that often will create a severe anemia in the newborn. The problem here is mostly hemorrhage in the mother. Although some severe cases can be found, and you have to be aware of that once you're there as a neonatologist accepting these babies for resuscitation. The second sort of side thing which they found, if there were a couple of babies which had 2 or 3 hemoglobins sort of tested, and they found that if you had an abruption, it's more likely that the hemoglobin will drop in the first sort of 10 hours after birth than if you didn't have an abruption, where it is more likely you have an increase in hemoglobin, which is mostly due to normal water redistribution. The second most commonest cause was the fetal maternal hemorrhage. And this is where blood from the fetus enters to the placenta into the mom, which we can test, which we use a Kleihauer-Betken acid dilution test, which measures hemoglobin F. And there are 3 different kind of formulas. I just mentioned one here, where the estimated fetal blood loss can be sort of calculated or estimated in the blood in mom. And as you can see there on the right, there is a not strong, but there certainly is a relationship with the percentage, which is as estimated fetal loss, and the actual hemoglobin in the baby, which can be quite significant in this cohort, which was published in 2014. There's one thing, and we had a case only 2 weeks ago. There was a big alarm. The Kleihauer was, 20%, and everybody was up in R. But actually, you have to realize, because the baby came out in perfect condition with a perfect hemoglobin. So this test can be false positive with maternal hemoglobinopathies. In some areas in the world, that might be quite common. We still don't know the exact pathophysiology of fetal maternal hemorrhage. We know it's a disruption in the placenta-decidual interface, but we actually don't know why it happens, and why it happens probably a little bit more in the term babies than in the preterm babies. This is a great study where they use sort of computer modeling and looking at the shear wall stress on each of the vessels within the placenta. And as you can see, with the density of the placenta, the vessels with increasing gestational age, there's actually less wall stress on these particular vessels. So the exact mechanism for fetal maternal hemorrhage is still not known. And then the third category was acute newborn hemorrhage. I think the most commonest one which we all have experienced is the subgaleal bleed, which we'll go to a little bit deeper. Subcapsular hepatic bleed. I've only seen one in my career, and a very difficult birth. And then, of course, in the preterm population, we have the pulmonary hemorrhage and the IVHs, which they definitely lead to hypovolemia, but maybe not as acute. We can find and diagnose these conditions quite easily, mostly from the history, but also from clinical signs, hemoglobin changes, and bedside imaging with ultrasound. What happens in the acute hemorrhage and hypovolemia in the physiological realm is that the first thing that happens, you get an activation of your autonomic nervous system and inhibition of the parasympathetic, which increases your heart rate, your cardiac contractility, and your arterial and venous tone. There is blood volume recruitment from the venous system, where the unstressed volume changes into stress volume. And there is blood volume recruitment in the arterial system, which is slightly different. They reorganize the blood flow from non-vital organs to the vital organs, which is usually your brain, adrenal, and your heart itself. And of course, there's activation of the RAS system. Looking in more detail in the clinical signs of hemorrhage, actually there is very limited neonatal data described about this. But if you go to the group which deals with this the most, you go to the trauma surgeons. And they have a fantastic ATLS trauma surgeon our sort of resuscitation guideline. They have their resuscitation guideline, and it's updated every day. It's freely available online, and they come with this particular table, which I find very helpful. So in the physiology and in the animal models, it would always start with tachycardia, then a decreased pulse pressure, where your mean blood pressure would probably still stay the same before you get a hypotension. And of course, if that persists, a reduced urine output. A couple of months back, we had a discussion about this, that some of my transport colleagues said, but I never see the tachycardia. That's not something which is there. And I think that phase is actually really short. So by the time the transport is required, you're already into the decreased pulse pressure and hypertension phase, where the heart rate actually can be lower. I will show you that in a case example. This was a term baby, uncomplicated first pregnancy. There was a need for a facilitated birth because there was meconium and non-reassuring CTG, and there were 4 attempts with forceps extraction. The EPCA scores were reasonable. The birth rate was okay. The baby didn't look that well, though. He was pale and was transferred to the NICU thereafter with some respiratory distress. This baby did develop quite quickly a tachycardia of 175, and even though the blood pressure remained relatively okay for a term baby, 50/30. The first pH was not terrible. The hemoglobin wasn't terrible, but the baby was deteriorating actually quite rapidly, where we saw the blood pressure drop to 39/19 within 1 hour. Ultrasound imaging found the location of the hemorrhage quite quickly. It was subgaleal blood, which was increasing every hour by about a couple of millimeters. We could even find some evidence of possible interparenchymal blood. We perform cardiac ultrasounds at the bedside. This is not a moving images, but this is supposed to be a a long axis view on the left of your screen, where you're supposed to see the left ventricular size in black and the right ventricular size in black in the first few hours after birth. And this baby, you could barely see it. There was also a very low stroke volume with a cardiac output less than 50. It's supposed to be at least 150 in newborn babies. We gave the baby some fluids. And then again, this ATLS edition will give you some idea of where you are, what is the response after the initial fluid resuscitation, and what you can expect thereafter. If you have a rapid response, you'll probably do well. You probably still need some blood, but you can check it out with the hemoglobins. If there is a transient response, quick improvement, and a decrease, thereafter, there's most likely you would need some blood. However, if you have minimal or no response, as was in this case, and the probably estimated blood loss is high, you need immediate blood, so emergency blood release. And of course, for the surgeons, need for operative intervention, which is not very common in the newborn situation. But that means you need to activate your massive transfusion protocol, your MTP. And this is important. You have to review if your unit has one, if your blood bank and systems and logistic around it are up to date and not too complex, because that can be very challenging, particularly in the remote areas and hospitals. This is one suggestion: transfusion RBCs, plasma and platelets in a 2:1:1 ratio, but there are different kind of ratios reported in the literature. What they do say, if you want to infuse it at that particular situation in the severe hemorrhages, you do need to infuse it as fast as you can. And of course, monitoring coagulation and electrolyte disturbances, which are rather common after you start your massive transfusion protocol. If delayed in transfusion is expected, which depending on the logistics and where you work, that can be quite a significant amount of time. I will show you in the next slide. Then you could consider another significant bolus of normal saline. This is a study from also Christensen and his group, but other groups in America doing the same thing. They started switching from components to whole blood as the sort of preferred transfusion product for resuscitating massive hemorrhage. And this whole blood is relatively easy to store, so it's low titer type O whole blood. It has everything sort of in it. And as you can see in this study, which was a study done in adults in trauma, civilian trauma. So even though it comes from the army, that is now used in civil trauma as well. And you can see the time to transfusion has been significantly reduced. And I can imagine, you know, in a true hypovolemia due to blood loss, the quickest way to restore it is restore the original cause, which is giving blood. So I'm actually not too certain if this is available in Australia, but we will certainly fish this out. And I've asked Robert Christensen to talk to us in June about this, and check out with our transfusion specialist if this is something we can soon expect or not. If it comes to cardiovascular support for hemorrhagic shock, again, there's actually no information in newborns to support your choices. There's a little bit of information in adults where they say choose noradrenaline or vasopressin if there is still room for venoconstriction. So those should generally not be the severest of bleeds, but thereafter you need to give adequate preload, preferably ultrasound sort of supported and diagnosed, and then inotropic support with adrenaline. This is the last slide about hemorrhage, where I think it's interesting to see in of this group again, where they looked at the changes over time in subgaleal bleeds, which is our most feared form of significant hemorrhage in newborns. They found that the severe requiring transfusion was relatively stable, but their mild and moderate rate has significantly increased. And they said this is actually because there is an increased understanding and educational program going around about subgaleal bleeds. And I know New South Wales started theirs a couple of years back. I'm not sure if we have this data for New South Wales, but I would expect it would look the same. All right, the number 2, hypovolemia due to dehydration. And actually here I draw the intravascular component, and in dehydration, most of the time, unless it's very severe, the intravascular component should still be reasonably filled, but that can be variable. If you look at the water and sodium balance during transition, we know that the fetus sodium water handling is very different than the newborn sodium water handling. In the fetus, the RAS system is highly activated. The ANPs are low because the left atrium is also low, so that gives sodium water retention. Then when you're born, that RAS system suddenly falls away. You get left atrium stretch, which is the normal transition, so an increase in ANPs, which will then lead to sodium excretion. And then, remarkably enough, this newborn will balance this out in a very few days, even though it has a very low sodium intake, because the first days of breast milk have a very low sodium content. But the baby does pretty well unless you lose too much weight. And that's, of course, for the term newborn who determines and can steer its own sort of regulation. However, after preterm birth, this fluid balance and the sodium-water balance becomes very different, because what is prescribed in, or what goes in, is mostly us prescribing the fluid. And what goes out, there is a higher proportion in preterms which have then transepidermal water loss. The urine output is slightly different. There is a component of extracellular water contraction and some smaller components in there. Extracellular water contraction, this is a systematic review of the 5 or 6 studies which have looked at this and have measured this. And the results are quite variable, I would say, in different locations, different times. They are rather old studies as well. But there is a change in total body water in the newborn, depending on your corrected gestational age or what is estimated. We know that the more younger gestational age have a higher proportion of total body water, and that the change in body water actually increases or decreases in percentage over time, but quite variable per study. Transepidermal water loss has been reported in many studies, and that's why we have all these babies in our cribs. And this is a study from 2013, which shows it per gestational age. And I thought it was a quite interesting study. How much mils per kilogram per day is water loss? And when you look at it, particularly when you look at the very young gestational age, the 22-weeker, but goes up on the first day of about 100 and 120, and then sort of drops back down to what is more expected. However, if you look at our textbook data, then I think we would sort of, this would be in the textbook data for 25 to 27 weeker. And I'm not quite sure we have made these adjustments to these different estimates of transepidermal water loss. And the main reason, I guess, why we have less transepidermal loss, because in the 90s we had very different cribs with variable humidity, and now we have these modern monsters, double wall incubators or triple wall with a very high consistent humidity. That makes diagnosing dehydration in the preterm also a bit more complex than the concepts which we are all trained with in the 90s. We used sodium, and particularly a high sodium in the first few days after birth, as a sign of dehydration. The assumptions were that the epidermal water loss was higher as expected, higher as we prescribed, so we didn't prescribe enough fluids, so clinical, we called that dehydration. But I think things have changed over time. There is an alternative here. Maybe there was actually a high cumulative sodium intake and the transepidermal water loss was actually lower as expected. So clinically, this is not dehydration, this is the opposite. This is sodium overload. And this is one study by Steiner from Europe, but there are at least 3 or 4 other studies which show the same. In our very young babies, under 1,000 grams, it is very hard to prescribe low sodium in the first 2 days of life, even though there's aspirin recommended of 1 to 2 in the first 2 days of life. Here, the average sodium intake on day 1 was 6, which would be the same in the little audit we did in our unit, going to 10 on day 2 and staying relatively high, which is a viable alternative course for the high sodiums in the early hours after birth. So I would summarize this dehydration, and that a high sodium early after birth does not always equal dehydration. If you want to interpret the serum sodium, you probably need more information, the actual fluid balance, which is difficult to measure, but you can look at weight changes early on and particularly calculate your cumulative sodium intake to interpret your sodium. If you then find that there is dehydration, it generally would not be severe and not intravascular. So fluid correction for true dehydration probably should take place slowly over the next 24 hours. The last category is the relative hypovolemia. And this is one of my favorite topics nowadays, where, as you can see here, as depicted in the venous intravascular system, there is actually the same amount of volume in that system, but because of the vasodilatation, there is now a relative hypovolemia. And it's uncertain how much of that volume is located as unstressed volume and how much is located as stressed volume. This is all to do and understanding of the regulation of vascular tone. This is a slide from Longley from back in the days, where he sort of summarizes all the regulatory aspects we have on our vascular membranes. You have angiotensin, norepinephrine, calcium channels, nitric oxide, and H-nitric peptides, which all play an important role into the balance between either vasoconstriction and vasodilatation. However, on the right, I've also showed that there are potent other vasodilators: bradykinin, histamine, potassium, H+, lactate, citrate, and CO2. And of course, we have our medication will have, to either of these mechanisms, also an effect on our vascular tone. The one which probably is highlighted the most is either inflammation or sepsis. And then inflammation or sepsis, there are changes in your calcium channels on your vascular membranes, which activates and changes into your potassium ATP channel, which is steered or driven by either high H+, so acidosis, or high lactate, or low ATP, high oxygen consumption. These lead to vasodilatation, which gives a decrease in blood pressure, which can then give decreased perfusion pressure and less blood to the organs. Interestingly, though, our approach to septic shock has been actually on this fluid. Fluid therapy in all the regulatory descriptors is number one in our approach to septic shock, while number two is cardiovascular medications, and number three is the hemodynamic monitoring. And this is being questioned now in the adult literature and sort of flowing over in the pediatric literature, and hopefully now arriving also into the neonatal literature, how we should address fluid therapy in relative hypovolemia. So who needs fluid, and where does it end up? And what happens if you give fluid? This is the Frank Starling curve, indeed back to physiology, with preload on the x-axis and stroke volume on the y-axis. And if you then have, if you're on the left side of the Frank Starling curves, on the lower ends, where you actually have low stroke volume and you give more preload, giving a fluid bolus, then most of these patients will definitely positively respond to fluid therapy. If you're in that middle bit, it probably becomes a little bit unpredictable how you will respond to fluid therapy. And particularly if you're on the right side of the Frank Starling curve, most of these patients will not respond to fluids and they might actually have some harm. And that's because there's an equal relationship between preload and extravascular lung water. All that water you put in will end up in the systems with the lowest pressure, which is usually the lungs or as edema. Do we have evidence that this is happening and why this is happening? We definitely do, particularly in preterm infants who have a different sort of stroke volume operating rates. They're higher on that curve. They're more likely, if you then give them fluids, to actually get into the red zone versus term babies, but each baby will respond individually. We have some of a very limited information on fluids and stroke volume. This is a very old study from David Osborne in 2002 already. 42 preterm infants with low blood flow, and they were as standard in those days were given 10 mils per kilogram normal saline before you started your inotropes. He didn't measure stroke volume, he only measured SVC flow, which is slightly different because that's on the right side of the heart. But still, you could argue, you know, some babies had an increase in SVC flow, which I guess is fluid responsive. Some were sort of in the middle, but some actually had a lower flow, even though they were already on low flow, and they might have had some harmful fluids in relation to the changes in blood flow. Harv and Segel, actually, they looked much deeper into it, and they looked at fluids and extravascular lung water. Their team just looked at the respiratory mechanics on the ventilator, and they looked at a smaller cohort, 16 preterm infants. Most of them had a blood pressure lower than gestational age, one of also our common scenarios which a lot of neonatologists will prescribe fluids, 10 mils per kilogram normal saline. And here you see the examples which I've taken out of the mean airway pressure, the oxygen percentage, and the lung compliance, which all changed, but not for the positive. Increase in mean airway pressure, slight increase in oxygen percentage, and particularly significant decrease in compliance up to the saline infusion here was about an hour, I think, and post-saline was 30 minutes, was 90 minutes after. You can already see a decrease in dynamic lung compliance with a normal fluid bolus. I was surprised here to not see any sort of significant changes between the population, but we can probably ask Arvind a little bit later. I think he's online. These are just examples in the newborns, and there's one other study which looks particularly at sepsis, but what all these studies have in common, whether you go in adults, children, newborns, or in the preterms, that when you give fluid, and particularly fluid overload, that leads to an increase in mortality or an increase in respiratory support requirements, as explained by the physiology. So the stories and the highlights and the editorials in the adult literature, as I explained, and now also in the pediatric literature, just how can we personalize fluid therapy? And I think the patients who have deserved most attention have been the ones with sepsis, but there are others which collect information about ICU patients overall. So for us as neonatologists, and in this situation, the question is, will a newborn with relative hypovolemia benefit from extra fluids? And if you want to put that into physiology, you know, will fluid end up as stress volume and stroke volume, which you can call fluid responsive, or will fluid end up as unstressed volume and then thus as extravascular lung water and edema, which is not fluid responsive and likely leading to harm? You can measure this fluid responsiveness in various different ways. You can actually change the interthoracic pressure because there's differences in the loading conditions with inspiration and expiration, but you need to have significant changes happening there to measure that. Or you can just increase the preload. And what they did already for many decades in the adult ICU, they did the pressure their leg, they raise somebody's leg, blood out of your leg will flow into your heart, and you could measure the changes in preload. However, that was sort of a bit arbitrary. So they came up, why don't we do the same as that passive leg raising, but we just give them a mini fluid challenge. We know exactly how much we give and how fast, and then we measure the changes. And it looks like this. This is called the mini fluid challenge. Again, the Frank Starling curve preload on the x-axis, stroke volume on the y-axis. If you on the left end of the curve and you give a fluid bolus there, what you would expect is a significant increase in stroke volume. However, if you're on the right end of the curve and you give the same fluid bolus for the same amount of time, you would expect a much lesser increase in stroke volume. This is what that looks like in real life. You take an ultrasound, you place it on the baby, you measure stroke volume before you give a fluid bolus on the left ventricular side, so the left ventricular output. You measure the maximum velocity and the changes over there. You give a fluid bolus, a fast fluid bolus, 3 mils per kilogram over 5 minutes. The adults came to that amount by looking at literally 1,000 patients where they had catheter data to validate which velocity and which volume would create the best sort of validated results. And it came back around 4-ish over a short period of time. So we chose 3 mL per kilogram over 5 minutes. And then you measure what the stroke volume does thereafter, and you can measure the change in peak velocity. And of course, there's still debate of what kind of change is considered a fluid responsiveness, but in most literature, there will be an increase of more than 15%. We did a little pilot study. We had 17 patients, 12 preterm infants with late onset sepsis, 5 with other pathophysiology, and we did the mini fluid challenge. And we found that 4 out of the 17, so about a quarter, were fluid responsive, which is more than 15% increase in that stroke volume. Which I guess, you can say 2 things. 4 out of 15 were responsive. So all the others were not responsive. And that means our fluid prescription model is certainly not ideal. What we also found, specifically in the babies with late onset sepsis, that their increase in oxygenation index 4 to 6 hours after that fluid bolus, same as Arvind found, was actually higher. They had more increase in oxygen. They needed more pressure and oxygen to maintain the same saturation, which can be explained from the physiology. It seems like this mini fluid challenge in newborns follows the same physiology principles. So how we can apply the physiology principles into clinical practice and can look at stroke volume and extravascular lung water changes. So this is promising, but of course, more research about this is needed, and particularly in bigger cohorts. This is what it then would look like if it is beneficial and you can manage this. You do a mini fluid challenge in clinical practice. If hypovolemia is likely, particularly relative hypovolemia, you do a mini fluid challenge. If that is positive, you consider further fluid boluses based on the clinical context, which means you need consider the degree of renal failure or cardiac dysfunction into that sort of decision making. However, if the patient is not fluid responses, you do not consider a fluid bolus at that time. And with this very simple practice, they found in 2 adult studies, and this is an example of one of them, where they measured patients with sepsis every 2 hours. And on the top, you see the fluid responders, which at the first one were fluid responders, and you can see the amount of fluid responders decreasing. Some of them needed 2, some of them even needed 3, and one of them needed 4 boluses to stop being a fluid responders. And at the bottom, you see the non-fluid responders, where only 1 or 2 of them later on developed still that they needed some fluid a little bit later into that process. But most non-fluid responders remained non-fluid responsive. And with that, they could, this personalized fluid resuscitation, they could have 25% less positive fluid balances 8 hours after the start. And it sounds trivial, but 8 hours after the start, having a significant increase in positive fluid balance is strongly associated with mortality. There's a little bit more to it than this simple approach to the mini fluid challenge. Of course, there will be babies and cases where you give the fluid, there was not an increase in cardiac output. That could also mean you didn't give enough fluid. These patients were so dehydrated and the filling pressure didn't decrease at all, and you actually need to give some more. So there were some methods and some ideas to look at this filling pressure, which is, let's call it challenging, particularly in newborns. The ideas which we have about it to give us some sort of insight in left ventricular filling pressure depends on this novel, or actually not novel, but methods which are not commonly applied in our newborn population. Pulse wave Doppler over the mitral valve, tissue Doppler looking at early diastolic inflow, speckle tracking here as an example of the left atrium and how that gets stiffer with increasing size. Or you can look even more complex. This is a high frame rate echocardiography example with over 600 frames per second, where you can look at the changes, not only looking at these pretty pictures, but you can make an inflow path and measure the changes at the lowest end of the left ventricle and the upper end of the left ventricle, which is called the interventricular pressure difference, which also is related to the amount of fluid and the pressure it generates within the left ventricle. These are all future research examples, but we still got a way to go. And I think particularly the fluid resuscitation and the mini fluid bolus has a lot of potentials. So I'm going to end here with the last two summary slides where I hope I have explained that hypovolemia is different. There is absolute hypovolemia and relative hypovolemia, and these are different pathophysiological entities. We know that acute hemorrhage is an absolute hypovolemia phenotype that needs acute assessments followed by blood cells where needed. We know that dehydration is a different type of this absolute hypovolemia, but also that it can be difficult to diagnose. I have shown you that relative hypovolemia is a different type, and I think it is the most commonest type of hypovolemia in the NICU. I have shown you that too much fluids prolongs ICU stay and is harmful not only in clinical practice and data, but also based on physiological principles. So I think we should at least try to test fluid responsiveness where possible. So the questions we ask initially: acute hemorrhage, is this baby hypovolemic? Yes. Will this baby benefit from more fluid? Absolutely. As a fluid bolus, yes. Do an initial fluid bolus, and if the response is not good enough, get red blood cells quick and urgently. More fluid is required. Dehydration, is this baby hypovolemic? Yes. Will this baby benefit from more fluid? Yes, but probably not as a fluid bolus. Maybe better as a daily increase where you gradually make sure you use those intricate water carrying channels, which are active processes within the body, and don't disturb it as much. And the last one, the relative hypovolemia. Is this baby hypovolemic? Intravascular? Maybe is actually the answer. Will this baby benefit from more fluid? Maybe. Do a mini fluid challenge. And if you then have a fluid bolus, I think that will work because you can build it up over time. All right. I will stop sharing and create some time for questions.
Right. Thank you, Koert. That's a fantastic talk. So I'll open it up for people to ask questions. I'll just try and get the screen. Until that time, just shout out if you've got a question.
Or place them in the chat.
Yeah, or place them in the chat. Here we go. There's someone in the chat. Okay, so Koert, I'll just start off with one of the questions that I was thinking about. Having just sort of thought a lot more about the renin-angiotensin system, it's not really part of your talk, but it was one thing that I was thinking about. How quickly do you think that that is activated in our preterm infants? And do you think it's gestation dependent? Does the 25-weeker respond as quickly as the term infant?
That's a very good question, and I don't think that's been properly studied. What I know about RAS studies in newborns is that there's various investigators had taken cord blood at different gestations and just looked what is the measure. And there was a huge variation from baby to baby. And even in the healthy term population, there was a huge variation. So that's just looking at one particular value. So can one particular value help you in thinking about this activation process? And I think the answer there is no. I'm not aware of any studies which looked at serial measurements over time, maybe in the twin-to-twin transfusion sort of realm, which you're going to talk about in a couple of weeks. But I'm actually not so sure.
So there's no more chats in the chat box.
It's a little bit no.
A transient increase in blood pressure may be seen with crystalloid infusion, which settles over a few hours. Is that a good endpoint for such interventions?
Oh, Arvind, you can unmute yourself while I'll answer Steve's question. What's the recommended inotropes, baby not fluid responsive in warm shock, vasopressor, and in cold shock and an inotrope? And somebody said, don't call it warm and cold shock because clinically babies don't respond that way. Call it just low stroke volume shock and call it high stroke volume shock. So low stroke volume shock, adrenaline or an inotrope, and high stroke volume shock, a vasopressor. Arvind, do you want to unmute yourself? Do you have time for that to ask this question?
Yes, thanks, Koert. Fantastic talk, as always. So I put my question in the chat. So of course, I'm not talking about giving blood in a baby who's born in a setting of fetal-maternal hemorrhage. That's something which is by and large an accepted practice and perhaps useful as well at many levels. The question was for hypotension. Again, there's a debate about what is hypotension, but if you generally start off to say, okay, lower mean blood pressure than what you might be comfortable with in a setting when there is no hypovolemia. So saline infusion would increase the blood pressure in a variable number of babies, and then that redistributes to wherever it has to and then settles down. But the question really was, is that a good endpoint for such interventions?
I think there's two components to the thoughts behind that, because if you look at the animal data, particularly from the Brisbane group, they say if you give crystallite to animals, it just leaks out like instantly. So what are you trying to create? Is it organ perfusion, or is it just intravascular volume and the blood pressure? So one question is related to what is the best clinical outcome? And to be honest, in a relative hypovolemia, in a high stroke volume shock, I think volume is not the best answer. The pathophysiology is vasodilatation. Why don't we treat it first with a vasopressor? That would be my opinion, and there is absolutely a move within the adult literature to earlier vasopressor use in high stroke volume shock. There might be different causes, I must admit, but in particularly inflammatory high stroke volume shock, earlier vasopressor seems to improve outcomes. The second bit is to the physiology of the mini fluid challenge. And that's a more tricky one. The older studies, particularly in pediatrics, they watched after an hour or after half an hour and then measured stroke volume. And actually, they didn't find as much fluid positive patients, because the fluid is probably already redistributed. So if you want to look at the physiology of the Frank-Starling curve, shorter time to determine effect is better. And I can only probably clinically translate to that study I showed you, and there's another study just like that, where when they use it, even in its simplest form, and that was mostly inflammatory high stroke volume shock, in its simplest form, they would prescribe less fluids than they would normally have done based on the parameters they used. And since the fluid overload is one of our biggest problems in raising mortality, I think we have something here. And so looking at the physiology, I think short-term effect is probably more important than looking at an hour's effect of what fluid will do. If you want to give more fluid, you think that's important. If you think this particular patient is on the left end of the Frank-Starling curve, you need to look very quickly, 5 minutes, 10 minutes, something like that, to then determine if you want to give more fluid. Your question about what's the clinically best to then give more fluid or not, we have no neonatal data to look at that. We have just some adult data, which they actually say that even that approach overall for the whole population leads to less fluid intake and less fluid overload. And I guess what they are highlighting, that this is an individualized approach instead of a broad concept. Give 10 mils per kilogram of fluid first and then do inotropies in babies with hypotension. And that's how we all sort of started. And I'm a big fan of the individualized approach, particularly if it's been supported with these physiological concepts. Does that answer your question a bit?
Yes, thank you.
So Koert, one of the other things that came to mind, and someone else has also put it into the chat, with the introduction of some of the neuro bundle of care, which has been done by Linda de Vries, one of their components was that all fluid boluses should be given slowly. And I don't think 3 mils per kilo over 5 minutes is the slow speed that she was recommending, certainly in the first 3 days of the baby. And I think the question here, what is the evidence for longer periods of giving saline boluses, like over an hour instead of a half an hour? So what made you come up with, when you were thinking about fluid responsiveness, the 5 minutes, which is actually a reasonable amount of volume to give? If you've got a kilo baby, that's about 5% of their blood volume over 5 minutes, maybe 4.2 or whatever percent. If they're 80 mils per kilo, if they're a bit less than that. So, do you want to sort of respond to that in terms of, there is a big push towards very slow giving of infusions?
Yeah, so it's an interesting thought. As you describe it correctly, I think there is a big push. It's people saying to people, but I don't think there is actually much evidence for it. And on top of it, most people are not aware, and I've only found that out recently. We give gentamicin 3 mils per kilogram over 5 minutes. And almost all of our small babies get gentamicin, which is interesting. It's the same amount over the same amount of time. So I think it falls into the safety range, unless you give gentamicin slower. I'm not sure who does that, but most people give it in that time in New South Wales formularium. Is slower better? So how do they get to the 3 mils over 5 minutes? That comes from the adult literature. And I know we can't translate everything to the adult literature, particularly if it comes to transitional medicine, but you could go 10 minutes theoretically. So the timeline and the amount is pure from their validated studies. And that's we will never be able to get validated studies because we don't put catheters into the left atrium or in the pulmonary wedge to give us that information about validation. So we will always be guessing. What I do think is if you give it slow, and one of the questions in this chat is also about, give more fluid over a much longer period of time. I don't think that will work for the physiological concepts. If you want to measure the change in stroke volume, you're better off changing it. And these babies already have a high stroke volume, most of them. So you're better changing it in a short period of time. If you want to give more intravascular volume or want to maintain more intravascular volume, particularly in sepsis, I think you should give a vasopressor and not the volume, because it will just leak out. What is better, I don't know. We don't know yet for sure what concept will be better. But I struggle to find the evidence behind that slow is better for your brain.
Okay. Do we have some other questions? There's no more in the chat. No one's got their hand up. Just unmute yourself if you've got a question.
Cheryl, if there's no one asking, then I might ask a supplementary question.
Yeah, go for it, Arvind. Thank you.
So, Koert, I'm talking about extremely premature infants here, who, the blood-brain barrier is quite immature, and the vasoregulation in the central nervous system is also quite tenuous, simply because of prematurity. So fast boluses of saline, I'm not talking about giving over 1 minute or 2 minutes, but even this half an hour, 1 hour, could it lead to enough fluctuation in cerebral blood flow transiently that it could contribute to intracranial hemorrhage as a cause and effect relationship?
I don't think we have that data, Arvind, and actually I think your data would support no, it's all going to get stuck in the lung. So that's a very big, vascular bed. So it's already dampened in the lung, like, the placenta would do before it goes to the brain. There is very old data which looked at some pulsatility changes in the brain, which I think it was a blood transfusion, and they did find some changes. But that's a blood transfusion, which I think is slightly different because of its viscosity and duration. But we don't have much data in this field to properly answer these questions. We do have a minimal amount of physiological data, including yours, where I think there's more and more evidence that I'm not so sure about this concept that blood which we put into the venous cannula will go into the brain. We do have the whole pulmonary venous bed and arterial bed still to dampen it out. And thirdly, if that's a bad thing, most of our babies in the extreme prematurity, if we have problems, is a hypoperfusion versus hyperperfusion phase. So maybe the question there is, in which phase are you supplying it? If you're already in the reperfusion phase and then you give a significant amount of volume bolus, I would probably, from a physiological perspective, agree that that might be harmful. However, if you give it in the low perfusion phase, I'm not so sure.
Okay, thank you.
I'm just going to ask one question of yourself, Koert, John Smythe here, and also Arvind. I mean, that subject's pretty close to what my thinking as well, and we know it's possibly hypoperfusion, hyperperfusion. Certainly, IVH is largely a venous infarction. So, you know, this capacitance of the venous system, venous pressure in those first 72 hours, and the business of fluid, it's very hard without pulmonary wedge pressure, is that we just don't have any means of sort of assessing that, do we really? And that would be the great thing for us to be able to do, wouldn't it?
So look here, the concept of IVH, venous distension pressure due to a bleed in the germinal matrix, which is obstructing venous return, is one of the concepts and hypotheses between the development of an IVH grade 4 or every periventricular hemorrhagic infarction. And you're right, we do not have the tools properly to investigate that in a continuous fashion. There are some bleeds which are related to the ischemia reperfusion, which might be the initial bleed is still the germinal matrix bleed, but that venous component and the pressure changes there in the venous system, I think, is difficult to explore.
Thanks.
Okay, so if there's no further questions, it's now 2 o'clock and we've had a really fantastic group. And thank you very much for everyone who asked some questions. Thank you very much, Koert. It was a terrific talk. And we'll just make a plug for all of these talks in the future. Thank you very much.
Thanks for attending. I think there's no session next week, but I'll put it on the advertisement. Otherwise, the week thereafter will be a session again. Thanks for attending.
Okay, thanks everyone.
Thanks, Cheryl.
Thanks, Koert. Koert?
Recording stopped.
When you were talking about relative hypovolemia, I didn't quite catch how you thought we would diagnose that other than doing a fluid responsive thing. How are you going to diagnose it?
I think you should do it based on your history. A hemorrhage is anemia, is relatively, there's a history and there's a low hemoglobin. I think 1 + 1 is generally 2, generally. Yeah, dehydration, tricky, you know, but I am pretty convinced that dehydration is generally not an intravascular problem, even in our smallest of babies. When we have high sodiums, or people think, or even with significant weight loss, if you look at the left atrium or the right atrium or the vessels, they all look very good size. So I think it is dehydration is certainly a problem. Don't get me wrong. Intracellular dehydration is damaging, maybe even more damaging than anything we think of. But intravascularly, so this is more of a maldistribution, which I think, you know, other changes are difficult to establish there. But relative hypovolemia, again, it's history. We have suspected sepsis, high stroke volume, that would, and a hypotension. I think you are then having a relative hypovolemia per definition.
Yeah.
Yeah.
Okay then. All right. Thanks a lot, Koert. That was good.
Thanks, Cheryl.
Bye.
Thanks for sharing. Bye.